Good evening, everyone. There is a 69-year-old male patient came to the clinic with complaints of diminution of vision in both eyes, right eye more than left eye, for 1 year, which was gradual and progressive. Diagnosed with glaucoma 7 years ago, and he was started on topical anti-glaucoma medications. So both eyes he was using travoprost eye drops 0.04% once in night, dorzolamide and timolol 0.5% 2 times in a day, and brimonidine and timolol 2 times in a day. No history of trauma or prolonged in medication intake. No family history of glaucoma or any other ocular problems. He was a known case of diabetes and hypertension since 8 years on medication. Personal history, snoring, and was positive for snoring and smoking. So on examination, right eye best corrected visual acuity was PLPR inaccurate, and left eye it was 630 and 10. Extraocular movement was full and painless. Both eyes. Hirschberg's corneal reflex test shows right eye exotropy and left eye orthotropy. Lids and agnexa were normal. Conjunctiva was normal. Cornea was clear. Anterior chamber Warren Herrick's reading was 3 in both eyes. Okay, ma'am. Right eye exotropy only.
And what's up for I wanted him to finish the slide to ask the first years to tell. Okay, so you should know what is a tropia and what's a phoria. And when you have one eye of PLPR inaccurate, no, they cannot fixate at all. So actually you will not be able to exactly measure and tell whether there is, you can only say that he is not fixating. So you cannot actually comment on phorias or tropias. I wanted you to commit that error so that we can tell, and then it will sink in better. You need fixation vision you need in both eyes to be able to decide whether the patient is tropic or phoric.
No, but with left eye he is fixing now.
You can only say when one eye is just PL, you cannot talk about it. Okay. If there is a gross lateral deviation, then you can mention it's a eye is abducted out. But you cannot talk about phoriatropia because tropia means Hirschberg, both pupils are looking at it. Okay. If you're not able to fixate, then he cannot.
Okay.
But this PL is a little doubtful. If he's very clear about PL, then he can still get a Hirschberg.
Okay.
Tropia, but phoria you cannot really comment because he's not going to fix it. I can go here, there, somewhere.
Okay. Right eye had RAPD, and lens status was nuclear sclerosis grade 2 in both eyes. Grade is grade 3, ma'am. It was. Means it was not constricted, it was dilated. IOP with Goldman applanation tonometry at 10:30 in the morning was 19 millimeters of mercury in the right eye and 21 millimeters of mercury in the left eye, along with 3 AGMs. Gonioscopy showed right eye anterior trabecular meshwork opening to scleral spur with TM pigmentation of +2, and left eye it was iris root closed and opening to scleral spur with TM pigmentation of +2 and scattered pars all around with pigmented Schwalbe's line. So and pachymetry in right eye was 454.33 microns, and in left eye it was 481.33 microns. Undilated fundus examination, both eyes shows the advanced cupping with pallor, and right eye showed collaterals on the disc. This is the fundus photo of the right eye, showing the collaterals and also the advanced cupping. And this is the left eye fundus photo, which is showing only advanced cupping with pallor. These are the fields. Left eye there is advanced field loss both in 24-2 and 10-2. And what else? What are the pointers and what else would you like to know about this patient? So management, we planned for left eye phacoemulsification with trabeculectomy plus mitomycin C plus intraocular lens implantation under guarded visual prognosis, and PI was referred because of the post IOP spike, and post IOP spike may occur, and dilation was done during the surgery, and neuroophthalmic opinion was obtained. They ordered MRI brain and orbit, carotid Doppler study, and sleep study. So in Doppler study of carotid and vertebral arteries, intimal thickening of both common carotid, internal carotid, and external carotid and vertebral arteries is seen. There is no evidence of carotid or vertebral stenosis. Then in MRI brain and orbit, there is a thinning of the optic nerves and chiasm, and in sleep study
So, how do you decide the glaucoma? Yeah. So, as Madam told, first differentiate whether it's a non-glaucomatous or a glaucomatous optic neuropathy. And as Ma'am was discussing, definitely the disc and the fields are not correlating, and the visual acuity, they are all not correlating when we have to look for any compressive lesion. And though the fields did not show any specific pattern, it's better to rule out any SOL. So MRI was indicated for this patient. And keratodoppler, with the considering the age and associated comorbidities, I think keratodoppler is indicated in glaucoma patients, especially in this patient with so much asymmetry, one eye PL vision with collaterals of the disc, where we have to rule out any ocular ischemia. So keratodoppler is also indicated. And the other study, that sleep study, here we have advised not for all patients studies recommended, but here since the patient had a history of snoring and the BMI was increased, Hussain, that was not mentioned in your case.
BMI was not mentioned, ma'am.
Okay.
But snoring was mentioned. Snoring was positive, ma'am.
Okay, so but since recommendation they have suggested weight loss, probably the BMI was also high. That the patient has been advised sleep study. And other history that we can actually ask whether underlying to suspect OSA are like, can anybody say what are the other the clinical features of obstructive sleep apnea? Apart from snoring, what are the clinical features that the patient can present?
Floppy upper eyelids.
No, those are all signs. I'm asking for clinical feature. You should ask for.
Ma'am, daytime sleepiness.
Yeah, daytime sleepiness.
Large waistline, obesity.
Yeah, obese.
Suddenly wakes up
From
in
the
middle of
sleep.
the
Correct.
sleep.
Disturbed sleep that they gasp and then wake up in the middle of the night, and these are the common daytime sleepiness. Okay. SV ma'am is there online? If ma'am, your comments on and opinion, ma'am.
Yeah,
regarding-
hi. Can you hear me? Audible?
Yes, ma'am.
Yeah, so I think other symptoms would also be irritable and lack of concentration, irritability and lack of concentration because of not a good quality of sleep. The indications for doing an MRI in a case of glaucoma would be, as Dr. Durga has mentioned, when there's a lot of asymmetry in the findings. I think that's about it. You've covered most of it.
Yeah, so basically, whenever we get across from glaucoma, it's I think for the kind of numbers that the glaucoma department sees, I think it's become intuitive for them to pick up where the disc is not matching. As very beautifully Dr. AVS has pointed out that the PAs were absent, not matching with the glaucomatous atrophy that the patient had, and there was what do you call it? There were collaterals at the disc. So all these things made her refer the patient to us. And once the patient is with us, how do we evaluate? We also see all those things, but then we start looking at we have to rule out the cause of optic atrophy. Now it's become, if it's not glaucoma, it's optic atrophy of unknown cause. I mean, like, there is nothing stopping it from being past, just post neuritic optic atrophy. So to answer your question, why an MRI? It can be the vision is lost in one eye, the other eye there is a constricting visual field, and the glaucoma consultant feels that it's not only glaucoma. Then you have to rule out SOL. Which SOL can cause shunt, these kind of blood vessels at the optic disc and pallor in a lady? I give you a clue. Meningioma. So the differential diagnosis which Dr. Avias was asking for the collaterals or the optociliary shunt vessels are advanced glaucoma, optic disc meningioma, what else?
Keratico-carotid fistula, CCF.
And vascular occlusions, as you said, CRP. Then, so that explains the MRI. Not only SOL, it could be, I said there's nothing stopping it from being, post neuritic optic atrophy. In fact, we have a case where it was a glaucomatous patient sent for, there is some amount of pallor and for opinion. And it turned out to be more positive optic neuritis. We don't know whether it's false positive or whatever, but there is nothing stopping it from being, two diseases can occur in one person. So if it is not matching, optic nerves have to be evaluated with, that's the standard now, doing MRI to rule out any optic nerve pathology. Then coming to sleep study. Now, sleep study and carotid Doppler, both the things are pointing to, they are done when you're suspecting hypoxia. There is associated hypoxic damage to the ischemic optic neuropathy component. If the person, now usual optic neuropathies are what? Compressive, inflammatory and ischemic, right? So compressive and inflammatory you have ruled out by doing an MRI. The that is ischemic optic neuropathy workup includes carotid Doppler and the sleep study. Now, usually carotid Doppler, is it done for ischemic optic neuropathy? Does it cause, a patient with a carotid artery disease, how does he or she presents usually? Carotid artery disease presents with thromboembolic phenomena, right? So a patient presenting with sudden, usually they'll present with emboli in the retinal vessels, right? And they present with central retinal artery occlusion or branch retinal artery occlusion. And it is considered as a kind of a warning stroke. Now, certain studies in US, when they evaluated, it is considered as you have to do a stroke protocol for these patients if they present with sudden thromboembolic, retinal, central retinal artery occlusion or branch retinal. So usually they don't present with ischemic optic neuropathy, right? But if that, usually ischemic optic neuropathy is because of the dysregulation of the vessels around the optic disc, right? What is the circulation of the optic disc? Yeah, and that's the circle of Zinn-Haller, right? So if there is an imbalance, those are small vessels. So it's a disease of micro vessels, right? Small vessels. And when there is an imbalance there, and that is why the night hypotension, when those are very small, delicate vessels, and at bedtime, if there is, you've taken antihypertensives and there is a sudden drop, those, how does ischemic optic neuropathy occur in those cases? That when the blood vessel is dropping, the usual thing is vasoconstriction, right? Usually, so if nothing is already going to the optic disc and on top of it vasoconstriction is occurring, there will be a ischemic optic neuropathy. So carotid Doppler doesn't fit in there, but it can cause micro emboli, and it has been rarely reported to cause ischemic optic neuropathy also, but it's not the common presentation. So and hence this patient did not show any stenosis. Sleep study again, hypoxia, but ischemic optic neuropathy. But the ischemic optic neuropathy caused by patient with sleep apnea, that is obstructive sleep apnea, is usually it's a kind of a chronic ischemic damage. It's not like, overnight patient will get up in early morning. Usual disc at risk when it develops ischemic optic neuropathy, patient gets up mostly say in the early morning. When I got up suddenly I had a decrease in vision. Here, this is not a typical presentation. This will not have a disc at risk also. Okay, both the things, in fact, if the patient ever presents to you with ischemic optic neuropathy with a carotid artery disease, it may not be a typical ischemic optic neuropathy, typical presentation. These are rare cases, where you can have these diseases and patient has an added here in Doppler disease, carotid artery disease, you will have a sudden, it's a thromboembolic thing coming from the carotids, and that can cause ischemic optic neuropathy. In obstructive sleep apnea, it will be a subacute kind of an added damage, and it's not proven. It's not proven.
Hussain didn't tell the color vision was 0 or 1.
Sorry, the color vision was 0 by 21, and yeah.
That was the most important.
Yeah, no one told. I asked what are the pointers, but no one told them. So it's okay, no problem.
The minimal visual acuity you need for checking color vision.
What are the eye diseases associated with we've already covered the carotid artery disease with obstructive sleep apnea. What are the associations? How can it optic neuropathy is caused by it?
Normal tension glaucoma.
Okay. One we said ischemic optic neuropathy, normal tension glaucoma. What else? Sleep.
Floppy iris, retinal. Floppy eyelids, retinal vein occlusion.
What else? One more neuro-ophthalmic condition. IIH, papilledema.
Yes, papillary.
IIH.
And one more point I would like to say, just look at when you send patients, like when you think that glaucoma is, the progression is worse and not correlating with your glaucoma findings, get back to the history. Ask the onset and the progression of vision loss. They might just say gradual, progressive, and on probing that slowly they will say, yeah, it was a sudden loss of vision. Then you should think that's something else. Probably, as madam was suggesting, ischemia usually presents with sudden loss of vision, or an optic neuritis. On top of glaucoma, the patient had a sudden loss of vision. Especially another condition in this age group is giant cell arteritis. So ask if the patient had a painful sudden loss of vision. Then you can think that probably any component of GCA. Okay.
Just give you an overview of sleep apnea and how you evaluate. Because many times patients come with report and we are only interested in reading the printed material. We have no clue. So she's going to give you an overview. Over to Pallavi.
Good evening, everyone. Sleep apnea can be central, obstructive, or a mixed mechanism. We will discuss about obstructive sleep apnea. It is the chronic disorder that disturbs breathing during sleep. The symptoms include loud snoring, excessive daytime sleepiness, insomnia, and morning headaches. Prevalence is around 2 to 14%. Risk factors include male sex. The prevalence is more in males. It is 3 times more than females. Age is it is seen more commonly in 40 to 70 years of age. Obesity, family history of obstructive sleep apnea, thick neck, and retrognathia.
Central sleep apneas are much more in older age group, above 70. So that's why age is important. Okay.
So there is intermittent apnea and upper airway collapse during sleep, which leads to hypoxia, hypercapnia, and intrathoracic pressure changes, which leads to autonomic, hemodynamic, humoral, and neuroendocrine dysregulation. So ocular associations of obstructive sleep apnea includes floppy eyelids, retinal vascular tortuosity congestion, papilledema, NaION, and normal tension glaucoma. So coming to mechanism of glaucoma in OSA, obstructive sleep apnea causes hypoxia in sleep, which leads to oxidative stress and inflammation, leading to mitochondrial dysfunction and retinal ganglion cell death, which leads to glaucoma. Vascular factors leads to affects the blood flow and perfusion of optic nerve, which also leads to optic nerve damage in glaucoma. And mechanical factors leads to supine position and obesity leads to increased IOP, which leads to glaucoma. So various studies have studied the prevalence of glaucoma in obstructive sleep apnea. Those studies found a significant association of glaucoma with obstructive sleep apnea, and prevalence they have found from around 2% to 27%. And this studies shows studied the prevalence of obstructive sleep apnea in glaucoma. In that also they found snoring as a risk factor for obstructive sleep apnea. So coming to diagnosis of obstructive sleep apnea, there is a stop bank questionnaire. It includes 7 questions to which patient will answer with yes or no. So first question is if the patient snores loudly. Second is tiredness. If the patient feels tired, fatigued or sleepy during the daytime. Then observed apnea, like patient anyone has observed that patient stop breathing or choke or gasp during the sleep. And high blood pressure, is he on any antihypertensives? And increased body mass index is also a risk factor, more than 35 kilogram per meter square. Age, if the age is more than 50 years of age. Neck circumference more than 40 centimeters, and male gender is a risk factor. So interpretation, 0 to 2 is low risk, 3 or 4 is intermediate risk, and more than 5 is more than 5 is high risk. Then there are 4 types of sleep diagnostic modalities. First type 1 is standard PSG performed in sleep lab. There will be a technician which will be attending, and it includes electroencephalography, electrooculography, electromyography, ECG, airflow, respiratory effort, and oxygen saturation. Type 2 is portable PSG. It is unattended, but the setup is same. Type 3 only cardiorespiratory polygraphy, and which is unattended, and type 4 only 1 to 2 signals, which include oxygen saturation or airflow. And coming to polysomnography, it simultaneous recordings of various physiologic parameters during sleep and wakefulness during including electroencephalography to identify wake versus sleep and its stages. So this is the setup of sleep study, polysomnography. It includes bilateral frontal, central and occipital EEG, EMG, and electrooculography, ECG, then audio and video recording from snoring, nasal pressure transducer, oronasal thermal flow sensor, pulse oximeter, and respiratory inductive plethysmography.
See, the EEG is to know your electrical activity of the brain, right? And why do they connect it to the chin and leg? Because this legs is a part of OSA. And chin, because you have to see, one of the reasons is because the palatal muscles and the mandibular muscles are getting relaxed, and there is laxity of the esophageal muscles. So that causes, pharynx. So that causes the pharynx to sag and close it up. So that is why the EMG of those is done. And why is EOG done when somebody is sleeping? To differentiate whether it's REM and non-REM sleep. Where do you expect OSA to occur? Much more in the non-REM time. Okay, so you need to correlate REM to non-REM sleep, and that's why EOG is done. ECG, of course, because you have to see whether there is any cardiac event occurring. That can be the cause or the effect of the sleep apnea. And pressure transducer, because all these things can be obstructive, no? So you need to know the level of obstruction. Some can be nose, some can be at the palate, or beyond that, near the vocal cord or the pharynx. Because if it is just a nasal obstruction, then you're only going to use a nasal CPAP. So to give the therapy also, you need to know where is the level of obstruction. Okay, and pulse oximeter, because your definition of OSA is also based on the oxygen saturation dipping. If you know the reason, no, then at least half the test we'll be able to write if we are asked to write a short notes. Continue.
Then we'll come to home sleep apnea study. It includes the portable monitors of respiratory parameters that records minimum of 4 signals. It consists of measurement of respiratory airflow, respiratory effort, oximetry, and heart rate. Respiratory airflow, nasal pressure transducer or oronasal thermal airflow sensor, respiratory effort with the help of respiratory inductance plethysmography, and heart rate with the help of oximeter. So coming to advantages and disadvantages of HSAT over polysomnography. Advantages are preferred sleep environment, reduced study cost, and reduced wait time for diagnosis and treatment. And it is suitable for immobile and limited access patients. The disadvantages are the study is unattended, underestimation of AHI and sleep apnea index because the whole sleep is not monitored. Negative or inaccurate study requires repeat study and not suitable for patients with neuromuscular disorders, respiratory weakness, and significant cardiopulmonary diseases.
If they have any of those things, when you do you are just going to get the OSA report. You don't know whether they had a cardiac event or a neuromuscular, like one of those paralytic diseases, and that can be a reason why there was oxygen desaturation rather than an OSA. So that is why those kind of patients you cannot do the home thing. The advantage is that with all these wires connected, I don't know who can sleep normally, but the chance of you sleeping in your normal pattern is much more at home. That's why they say at least you should do it for 2 days before you interpret the results.
Coming to the definitions, apnea, if there is a drop in respiratory effort signal by more than or equal to 90% of pre-event baseline for more than or equal to 10 seconds and continued or increased inspiratory effort from chest or abdomen. Hypopnea, when there is drop in respiratory effort by more than or equal to 30% of pre-event baseline for more than or equal to 10 seconds associated with oxygen desaturation of more than or equal to 3%. Or by 4% by various criteria.
So, just to simplify, apnea is a pause in breathing, hypopnea is shallow breathing.
Respiratory effort related arousal, if there is a flattening of the respiratory nasal pressure for more than 10 seconds, causing an arousal from the sleep but not meeting the criteria for apnea or hypopnea. So coming to interpretation, the severity of OSA is determined by indices, apnea, hypopnea index or respiratory disturbance index if PSG is performed, and respiratory event index if home sleep apnea test is performed. Apnea hypopnea index, how we calculate it is number of apneas plus hypopneas divided by total sleep time. Respiratory disturbance index, number of apneas plus hypopneas plus respiratory effort related arousals divided by total sleep time, and REI we calculate it by number of apneas plus hyperapneas divided by monitoring time, which is calculated in HSAT, home sleep apnea study. So severity grading, less than 5 per hour is normal, 5 to 14.9 per hour is mild, 15 to 29.9 events per hour is moderate, and more than 30 events per hour is severe. So treatment include lifestyle changes which include weight reduction and sleeping in lateral position, positive airway pressure, and oral appliances therapy and surgery. So positive airway pressure, it includes CPAP and BiPAP. Continuous positive airway pressure, it is the first line of treatment. It works via pneumatic splinting of the upper airways. Airway pressure will be applied through oral, oronasal or nasal devices depending on the where is the obstruction. And adherence rate ranges between 17 to 85%. It also lowers blood pressures, rates of arrhythmia and stroke, improves left ventricular ejection fraction in patients with heart failure, and improves the rate of fatal and non-fatal cardiovascular events. So this is how the oral masks of CPAP, and it is connected to this CPAP machine.
This is a nasal one. Basically, positive pressure, because there's so much of positive pressure pumped in that it pushes open and air will enter. What is the minus of the CPAP is that when the patient exhales, he has to exhale against that little resistance because that resistance is going to be constant. So if they don't have the capacity to exhale well because their muscles are not strong enough, then CPAP will not work, in which case you use the next one.
Bilevel
That's
positive
all.
airway pressure.
You go to the next slide.
So, if patients can't tolerate CPAP, the oral appliances therapies are there, which include mandibular advancement devices and tongue retaining devices.
Basically, anything that will obstruct. If your tongue is falling back, push it forward. Otherwise, if the palate is coming down, the palate is very prominent, then you cut the palate away. The adenoids and tonsils, really, they cut the palate away and put on plastic arch. But after 6 months, 1 year, there is erosion and it comes out. So, all those things are plus minus.
Then, depending upon the level,
That's what they are telling. All
cause,
this.
surgery can be done. Bariatric surgeries can be done in obese patients. So, coming to treatment based on severity, in mild obstructive sleep apnea, which primary treatment is observed positional therapy, and secondary treatment is CPAP, and adjunctive include weight loss and positional therapy. In moderate, CPAP is the primary treatment, and oral appliance or surgery are secondary treatment, and weight loss and positional therapy is adjunctive. In severe, also CPAP is the primary treatment, and weight loss and positional therapy are the adjunctive treatment. So this is the polysomnography report of the case. So we can see that they have given a number of apneas, number of hypopneas. So adding together apnea and hypopneas divided by total sleep time, we calculate the AHI index, which was 35.5 in this case, which is severe OSA. And also pulse rate and oxygen saturation is measured, which is shown in the graph on right side. So pulse rate was average pulse rate was 60 beats per minute, and average saturation was 91%, but we can see the drop till 70%. Thank you.
We'll go to the next case.
Yeah. Good evening to all. The second case is of a 75-year-old male patient who came to us with complaints of gradual and progressive diminution of vision in the right eye for past 1 year. He also gives a recent diagnosis of glaucoma after checking up locally in his hometown, but baseline intraocular pressures or records was not available with him, and he was also not on any topical anti-glaucoma medications. He gives similar history 10 years back, for which he underwent a cataract extraction surgery. Systemically, he is a hypertensive on medication, and he also had undergone a bypass surgery in 2020, for which he is on anticoagulants and antiplatelets. On examination, he had an uncorrected visual acuity of 618 N18 with no improvement with correction. His left eye uncorrected visual acuity was 6/9 N8, improving to 6/6 and N6 with correction. He had an intact color vision in both his eyes. Extraocular movements were full and painless. Anterior segment examination like lids and adnexa, conjunctiva, cornea were unremarkable. He had a shallow anterior chamber in the right eye with a Von Erich's grading of 2, and left eye was normal in depth with Von Erich's grading of 3. Also, he had an immature cataract of nuclear sclerosis grade 3 to 4 in the right eye and PCIOL in the left.
Go back. Whatever be the cataract, it cannot be N18. That's a rule that is never broken. Most of you sleep over it when you admit patients, when you operate on patients. Cataracts can never make it N18 unless it's such a dense sheet of PSC that no light is going on the other side. Okay?
Intraocular pressure by GAT was 14 in both the eyes. Gonioscopic examination was the angle was closed in dim illumination but was open on compression. The trabecular meshwork pigmentation was uniform in all 4 quadrants, and a focal pass was seen superiorly. The left eye showed an open angle, for which he underwent a YAG peripheral iridotomy on the same visit, and he was started on post medications as well. The central corneal thickness was 483 microns in the right eye and 496 microns in the left eye.
If you see a patient, one angle opened, right? Post cataract surgery, other eye is closed. Does it tell you anything about the disc changes that can be there? You can have a pallor just because of that, because they can keep having spikes of IOP because it was a closed angle. So keep that also in mind when you evaluate a patient, because if nothing else fits and only a little pallor, there's no need to send them to a neurophthal cross because they might have spiked in the past and we may not be aware of it.
We did a visual field analysis of the patient in that visit. Would anybody like to interpret this printout? Any PG?
Ma'am, it's a right eye single field analysis. It's a central 24-2 test. Age of the patient is 75. The stimulus used was a size 3 white stimulus. It's a CETA standard test and pupil diameter was 5.5. The visual acuity has been corrected. There is refractive error given. False negative errors seem to be significant in this. False positive errors are within normal limits and fixation losses are okay. Foveal threshold is 31 decibels, which is acceptable. The Pattern standard deviation, ma'am, shows a superior and inferior arcuate type of a defect, and glaucoma hemifield test shows outside normal limits with visual field index of 78%.
Okay, so when we always start with reading a visual field printout, always start with the topmost part where we are actually seeing if the patient that the printout belongs to the patient that we are examining. And the patient ID is important for documentation also. Date of birth is very important because you're comparing the data of the patient to the normative database. Next, it would be the topmost part where we are looking at all the parameters that Shamika pointed out. Apart from that, we always look for which test we are doing, which is 24-2 test. Next, we are looking at the strategy, Sita standard. So next we have to look at the reliability indices. Here we first is the fixation losses. 2/17 is somewhere around 11. Anything less than 20% is a reliable test. False positive should be less than 15%. Here it is just 1%. False negative should be less than 20%. Here it is 16%. So it is a reliable field. Coming to the foveal sensitivity, 31 decibels is actually a less foveal sensitivity, but it is corresponding to the visual acuity of 0.33, which is somewhere around 6/12 to 6/18. Next, we have to look at the raw data here just to figure out if the blind spot is located in the right position, just to confirm the eye is correct in the printout. Then we can take a look at the grayscale, which is going to give us a gross trend of how the visual field is going on. Next, the total deviation numerical plot. This is the total deviation numerical plot. This is obtained from the difference between the normal retinal sensitivity from the patient's retinal sensitivity. And this total deviation probability plot is obtained by the scotomatous depiction of these deviation points. So this is given by the probability values. This particular fourth ring that you see here, it's going to be representative of the values in the above numerical plot. So lower the value, it's going to be increasing in clinical significance. Now we can see here that there is a generalized reduction in the visual field sensitivity of the patient, whereas in a pattern deviation, it is going to pick up all the deep scotomas that the patient has by reducing this generalized depression. So this particular points will be derived from the numerical plot of the total deviation, and that in depiction is going to give you a pattern like this. Looking here, we have dense depression points more in the superior hemifield, respecting along the horizontal meridian, but not involving the central fixation here. Then looking at the statistical indices in to the corner, we have the mean deviation, which is going to be giving you the average of the total deviation numerical plot, which is -10. Higher the mean deviation, more irregularity is seen, which means the visual fields is worse for the patient. Next is the pattern standard deviation, is the standard deviation of all the numerical data from the total deviation point. Here it is 8.45. Again, it means it is irregular or there is disturbance from the normal hill of vision of the patient. Next, we look at the visual field index. It gives a gross percentage of how the total overall visual field of the patient is. It can range anywhere between 0 to 100. Here the patient has 78%. Next comes the glaucoma hemifield test. Here we have 5, but here how it is taken, it as looking at the raw data, it's going to be dividing it into 5 different zones, which is going to mirror from the superior and the inferior part. Deriving from that, it's outside the normal limits, means that all the values are seen in less than 1% of the normal population, which means that patient has a field defect here. This is the left eye visual field printout of the same patient. Again, after verifying the printout is belonging to the patient that you are examining, let's come to the reliability indices. Again, looking at all the fixation losses, and the fovea doesn't match with the visual acuity here. And looking at the grayscale, we can see that there's a superior hemifield involvement. Again, coming to the pattern deviation probability plot, there is a involvement of the superior hemifield involving the central fixation in this left eye. So we had done a 10-2 for the same patient. That is also depicting the same thing with involvement of the fixation. After patency of the PI was confirmed and gonioscopy was performed again to confirm the open angles, we did a dilatation and fundus examination of the patient. We could see here that the patient has a marked cupping with a 0.8 vertical CDR ratio with superior and inferior thinning, and there is also a tortuous vessels over the disc area, and there are also bayoneting of the vessels which can be seen because of the neuroretinal rim thinning. Any obvious RNFL defects are not to be seen in the right eye. Coming to the left eye, we can see the obvious pale color of the disc compared to the right eye, and also cupping is somewhere again 0.8 to 0.9 vertically with the inferior thinning of the neuroretinal rim. Bayoneting of the vessels are also present, but any obvious RNFL defects are not to be seen, and probably because of the tessellated background of the patient, of the fundus. This is a red-free image of the same. Next, when we are comparing the visual field of the right eye to the fundus examination of the disc of the right eye, we could see that they don't correspond very well with each other. And also for the left eye, given the gross pallor of the optic disc and the attitudinal field defect of sorts in the visual field, we suspected the patient could be having any other association along with the low tension glaucoma or added on primary angle closure glaucoma, and a neuro-ophthalmology opinion was obtained.
Just go back. See, when you look at a disc like this, you see the nasal rim. Invariably, because the nasal is the last to go, it will always be pink, even if it's 0.8, 0.9. If you see the right eye, it is definitely a little pinker when compared to the left eye. And the nasal rim doesn't turn pale. There has something going on. And definitely arterial sclerosis, you can see here and there, you see the supero-nasal vessel and all. You can see little narrowing, intermittent narrowing, supero-nasal, that side, artery. Just go above the disc a little. Yeah, see that? There is a little narrowing in the blood flow intermittently. Here again, inferotemporal down at 6 o'clock, what is going? You can see the arteriosclerosis there. So you know that there is some other circulatory issue also in this patient. Go to the other disc. In this disc, if you see, there is temporal pallor, which you expect in any patient. You can have a little pallor. But again, nasal rim, whatever you can see, is also not as pink as the inferior rim is pinker than the nasal, which is again some clue that some ischemia is going on. And if you see that the field effects, you won't call it a real altitudinal, because beyond the disc, blind spot, you don't have field effects. If it's neuro-opthal, it will be completely horizontal. Am I right? Beyond the optic nerve blind spot, you should have complete 0, 0, 0. If you have this kind stopping that, then there is a more glaucomatous component to the ischemia. It's not a pure AAON. Correct, no?
Ma'am, also opinion on ischemic optic neuropathy in a large disc, ma'am. SRB, ma'am.
Yeah, so we all know that ischemic optic neuropathy is typically seen in a disc at risk, right? That is in around 95%, some people say 97% of cases, ischemic optic neuropathy occurs in a patient with a disc at risk. Those rare, whatever 3 to 5% of eyes where you get ischemic optic neuropathy, we have seen one. Very rarely you can have an embolus coming from the carotid artery disease. You need not have a disc at risk there. Then in sleep apnea, there you can again have chronic subacute, these are the words used for ischemic optic neuropathy in patients with sleep apnea, ischemic optic neuropathy. Then post-cataract surgery ischemic optic neuropathy is another ischemic optic neuropathy which may not occur in an eye with disc at risk. It's a rare phenomenon and you have to look for these causes. This talk is actually about those rare causes of ischemic optic neuropathy where you don't have disc. This is what you call it. These are the rare few cases. I'm not getting the exact term. where like it's where it is not proving the what is it called? Not proving the rule. Exception. These are the exceptional cases. You know, the usual rule when you're saying ischemic optic neuropathy, you have to look for a disc at risk. Only 3 to 5% of patients, it is normal looking. Here it is a large cup disc actually. If you go back to the right eye visual field and the disc here, it is I mean, like it's not. Why is it not a glaucomatous field defect? Anybody? Why wouldn't you call it glaucomatous field defect? Is the right eye? Where is the blind spot? Here, it is the temporal, right? The field defect is more temporally. Usually, I don't know, glaucoma team is here, but you say that the nasal, you know, your very early primary teaching of differentiating between glaucomatous, non-glaucomatous is that usually nasal field is affected in case of glaucomatous optic disc damage, and you can have neuroophthalmic causes, but this is not even looking like, is this how an ischemic optic neuropathy presents? Ischemic optic neuropathy is what we have in the other eye. Rather, it's an altitudinal defect that you'll get. In case of here, what is happening then? What is this field defect? Not this one, the previous one in the right eye. It is a peripheral constriction. You will see this kind of field defect in patients with papilledema, right? Now, I'm not saying that this is a case of papilledema, but this is how you see, no? The peripheral, if you have optic neuritis, your central field goes. If you have ischemic optic neuropathy, traumatic optic neuropathy, altitudinal defects. If you have this kind of a peripheral defect, it's asymmetric, it's more on the temporal side, but it's something happening in the periphery, okay? So it could also be a retinal cause. Retinitis pigmentosa patients, right? So something, so if it is temporally, that means something in the nasal retina. So this is not actually fitting into neurophthal or glaucoma right now. Let's see what happens later. Proceed.
So an MRI brain and orbit was ordered along with the carotid Doppler. The MRI brain and orbit did not yield any significant finding except for an old infract seen in the right gangliocapsular region and corona radiata. And the carotid Doppler showed a 30 to 40% stenosis on the right side and 20 to 25% stenosis on the left side. According to the North American SCET trials and the European carotid surgery trials, they say that any stenosis less than 50% could be a mild form and it does not really warrant a surgical intervention. But when a patient was given a vascular surgeon opinion, they did a CT angiography and was found to have 60 to 70% stenosis of the right ICA origin. Any stenosis that exceeds a 70% grade, right carotid endarterectomy is warranted to prevent any episodes of stroke in the patient. So patient was advised to undergo that particular surgery and was advised to obtain clearance post that surgery for a right eye cataract extraction surgery in our hospital. In the meantime, patient was started on latanoprostene 0.005% HS in both eyes. Patient did undergo that surgery and came to us 2 months later for right eye phaco. Post-operatively, patient was started on brimonidine 0.1% BD and latanoprost was continued on the left eye and intraocular pressure was 14 in both eyes. 8 months post-operatively, patient was still compliant with anti-glaucoma medications, after which the visual fields was repeated. This is the new visual fields, which was very similar to the baseline visual fields we obtained 8 months prior. The VFI is still 79%, GST is outside normal minutes. There is no change in the mean deviation as well in the right eye. Left eye also showed similar findings.
Dr. Sripriya, can I ask a question? it can the patient had cataract surgery. So can that
No, the generalized
any of
reduction,
this-
the mean deviation is a complete hill of vision was lesser in the right eye. So if you see the total deviation plot, the whole thing is dark. That is because of the cataract. But the what is retained in the pattern deviation plot, that is because of the optic nerve ischemia. That gradually with time the density started coming down and it has improved to this level. What you're selling is
and
right.
what happens to the disc at this time?
Clinically, the disc did not look any better. Actually, we don't have a pre-op photograph of that disc. This is the disc post-op, which for class sake we put it as pre-op disc.
Okay, because of the cataract we could not take.
No,
the
no,
good
we never
photograph.
thought of taking the. We don't take discs of every patient, no. So
Patient,
we
right.
didn't take, but only
Right.
because it was improving and we wanted a documentation, we took it and then we didn't expect the fields to improve so much. So we use the post cataract surgery, which is the post endarterectomy picture, as the picture for description in the class.
Thank you. So thanks.
Thank
for-
you, Meena.
sorry
But what you
for
said is so
interrupting.
true that total deviation plot, that is the generalized reduction of the NS4 that the patient had. And even in the absolute numbers also, you can see that the next to the spot, all those points are close to 0, whereas the rest is around 24, 25, which is what you expect because of the cataract reduction. Continue, Amrita.
Patient was again asked to review along with another Doppler report. We were able to find that there was a non-calcific plaque in the right mid and distal common carotid artery causing 30 to 40% stenosis, and a mixed plaque noted in the left carotid bulb extending to the left proximal ICA causing 50 to 60% stenosis. So the patient was again asked to review back with the vascular surgeon in view of carotid insufficiency, local IOP monitoring, and to review after 3 months.
Good evening to everyone. So today I am presenting the short presentation regarding the carotid Doppler, general principles and technique. So what is the carotid Doppler? So it is an ultrasound non-invasive medical test which use the sound waves to assess the blood flow through the carotid arteries in the neck. The principle is that the probe emits the high frequency sound waves that traverse into the body, and when it encounters the moving RBC, they bounce back with the changing frequency, which is known as a Doppler effect. This frequency shift is directly related to the speed and direction of the blood flow, which allows for the measurement of the blood flow velocities, detection of plaques, and assessment of stenosis of the carotid artery. So this is the same figure which illustrates the principle of the carotid Doppler. So there are two positions. One is the overhead position, in which right hand is needed for right carotid artery assessment. Coming to the patient head position, so use of pillow can produce the poorer window for the carotid artery. Optimal patient head position is tilted about 45 degree away from the artery being examined, and neck of the patient should be relaxed. So now coming to the anatomy of carotid artery, so as we can see that from the arch of aorta, brachiocephalic artery arises, and from the brachiocephalic artery, right subclavian and right common carotid artery arises, while the left common carotid artery directly arises from the arch of the aorta. So on the Doppler, we can see the right carotid artery, right common carotid artery, but we cannot assess the left common carotid artery. Now coming to the difference between the internal and external carotid artery. So internal carotid artery is posterolateral to the external carotid artery, which is large in size without any branches. So because of that, there is a small Doppler velocity, and to differentiate, there is a temporal tapping technique. So basically, the superficial temporal artery is a branch of external carotid artery. So when we tap the temporal artery, it produces the Sherrison-like artifact, which we can see in the left side of the figure. To the intima media thickness, so as you can see, there are two bright lines. The upper bright line is the interface between the blood and the intima, and the lower bright line is the interface between media and adventitia. So normal intima media thickness should be less than 1 millimeter. If it is more than 1 millimeter, it is associated with the risk factor for the stroke and myocardial infarction.
So he is telling what are all the things that they look at when they do a carotid Doppler. So one is the IMT.
Second is the plaque. So in the plaque, we see the echogenicity, surface, and the ulceration. So echolucent are the more vulnerable for the stroke. Irregular surface is also more vulnerable for the stroke and MI. Now, ulceration is defined as a depression of the plaque surface by more than 2 millimeter.
See, even in the previous one, they told the carotid report that Dr. Amrita told was about the plaque being highly reflective, calcified something. So when it's calcified, you don't expect it to be mobile because it is adherent and stuck there. So that is why when you talk about just go to your previous slide, the plaque morphology matters because when it's more echolucent, it is not very solid. So it is going to easily dislodge. That is why it has a higher chance of stroke and myocardial infarction. Similarly, any irregularity means it can dislodge because there is more rough area, more turbulence, more chances of it dislodging. And ulceration also indicates that there is dislodging all the time. So these are the things that you also look at. And IMT you will get only with in your 2D echo you will get that. If you want to really know the plaque morphology and volume and all that, you need a 3D echo. So you have to know which echo, what type of a color Doppler, carotid Doppler they did.
Coming to the plaque volume, so it is a 3-dimensional ultrasonography which is used for the atherosclerotic treatment. So it increases without the treatment and decreases with the statin. So it is more sensitive parameter than the intima media thickness for the plaque progression. Now this is the figure. As you can see, there is a longitudinal scan of the distal common carotid artery which shows the plaque with mixed echogenicity, and the calcific lesion is seen in that. But the surface of the plaque is smooth. Now this is the same distal common carotid artery, but the transverse scan which shows the low echogenicity, and as you can see that centrally lucent area is there. So it is a higher risk of the stroke will be there. So this is the picture of the 3D picture which shows the plaque volume. Now coming to the grayscale median, a grayscale median of the blood pool is 0 to 5 and adventitia is 185 to 195. And the study says that grayscale median less than 25 has a higher chances of stroke risk. That's why the echolucent plaque is more vulnerable. Now color Doppler is the encoded velocity information of the grayscale images, which is good tool for visualizing the blood flow in the vessels and finding the stenotic segment. So for proper velocity, the Doppler angle should be between 30 to 60 degree, while for the IMT probe should be parallel to the blood vessels. In figure you can see that in the right side the probe is parallel to the blood vessels for the IMT for intima media thickness, and for the Doppler it is 30 degree. Heel and toe technique is used for that, in which tilting of the probe from head side to the toe side create an angle between the surface and the vessels. Normal velocity of the common carotid is 30 to 40 centimeter per second. Pulse wave Doppler is used to measure the exact flow velocity. Now here are the definitions. So peak systolic velocity is the highest velocity of the blood flow during the heart's contraction phase, which is measured in centimeters per second. Second is the end diastolic velocity, the blood flow velocity of the heart at the end of the relaxation phase. And the internal carotid artery and common carotid artery peak systolic velocity ratio, which grades the severity of the stenosis. Another most important term is the resistive index term, which is a proportion of the difference between the peak systolic velocity and end diastolic velocity to the peak systolic velocity. The normal range should be within 0.6. Now here is the criteria of the ICS stenosis as per the Radiological Society of North America. As you can see that normal and within 50% of the stenosis, the peak systolic volume is less than 125, while the end diastolic volume is less than 40. For 50 to 69%, it should be 125 to 230 and 40 to 100 in the end diastolic velocity. Near total occlusion, it is variable, and total occlusion, it is undetectable.
So more narrow the vessel, more is the turbulence. So the blood is going to go faster because it's velocity, not the volume of blood going. So more the narrowing, higher will be your values.
So here are the normal images of the normal carotid Doppler images of the internal carotid artery. As you can see, there is a good blood flow without any obstruction. The second image shows the 0 to 49% of the ICS stenosis. Here you can see that plaque is there, and the values of end diastolic volume, peak systolic velocity is 125 to 230, and end diastolic velocity is 40 to 100. The fourth picture is the plaque is there, almost obstructing the vessels, but it is less than the near occlusion.
Basically, you cannot see the blood flowing at all, no, and also see the A waves, just like your ultrasound scan. So that gives you the peak systolic and the end diastolic volume, because you may not have Dr. Veena every time reporting, no, wherever you are. So you should have some idea about what images you are seeing, and just go to the earlier image.
Yes.
You can see the turbulence there. See the turbulence? That's the left side is the normal internal carotid artery, and this is like a ICA. See how much of stenosis, how much of irregularity is there in the waves, and the rise of the peak systolic volume also, no, it's close to 100. So there's an acute rise, and then there is a turbulence as the blood regresses back when there is the diastole of the heart. So this is an indirect clue for you also to know that the carotid Doppler is not okay.
So here you can see that near occlusion, which which shows the reduced flow in the internal carotid artery, and the total occlusion in which we cannot able to detect, we cannot able to see any flow. Coming to the reports, here we can see that the right internal carotid artery proximal part shows the peak systolic velocity of 96.7 centimeter per second, and the right internal carotid artery of the distal segment shows the 73.86 peak systolic velocity. Left you can see it is 101, and left internal carotid artery distal it is 98.72%. So in both the color Doppler, the blood flow is good without seeing any plaque, but the intima thickness is there. So this is the report of the patient, in which we can see that internal thickening of the both common carotid, internal carotid and external carotid artery, but there is no any evidence of the carotid stenosis. Coming to the second report, as you can see, there is a less peak systolic velocity, only 44.12, and the right internal carotid artery, and diastolic velocity is also less. So if we can see that resistive index is more than 0.6, it is almost 0.68. And in left internal carotid artery, you can see the spike of the peak systolic velocity, which is around 90, and end diastolic velocity is 23 with a resistive index of 0.74. So this is the report. As we can see that, if you can see that compared to right eye, left eye,
And a
the
resistive index of what is normal? Tell them that. You didn't tell.
0.6 up to 0.6.
More than 0.6 means there is resistance.
So here you can see that resistive index of the left side is more compared to the right side. So there is a 40 to 50% stenosis involving the proximal right internal carotid artery, and 50 to 60% stenosis involving the proximal left internal carotid artery. And there is a diffuse irregular intimal thickening involving the bilateral carotid and vertebral artery. Coming to the third case, so this is the right internal carotid artery. As you can see, there is a hardly any flow is there. In the left internal carotid artery also, there is a undetectable peak systolic velocity. So this is the complete occlusion of the bilateral common carotid and internal carotid arteries, right more than left. Only vertebral artery shows the peak systolic volume, that too with the more resistive index. Special thanks to AVS ma'am, DAP ma'am and Shushrut for the images and guidance.